Hi folks, and thanks for joining us for another Mindout webinar. My name is Charlie Wilbridge and I work on the Mindout project here at the National LGBTI Health Alliance. Before we start, I just want to acknowledge the traditional owners of the land in which we are meeting on today and pay my respects to their elders past and present. Today we're continuing the Intersex awareness conversations. Previously we've had Bonnie Hart present the Understanding Intersex webinar, which is available on our Knowledge Hub on the website. And today we have Morgan Carpenter, who is the Co-Executive Director of OII Australia. So I will hand over to Morgan now and he can run through his webinar. Thank you, Morgan.
Mine is now unmuted.
Just for the sound there. Hello, it's nice to be here. My name is Morgan Carpenter. I have a few hats, as you can see. As of 1st of December, I'm a co-executive director of OII International, OII Australia rather, which is a national intersex-led organisation. I'm also the founder of a small project founded or based upon Intersex Awareness Day, and I'm a consultant to GATE on bodily diversity issues. So before I go into the webinar in much detail, I'd like to acknowledge that I'm speaking from Gadigal land, and I'd like to pay my respects to elders past, present, and emerging. And I'd also like to pay my respects to elders of the intersex community. So to begin, I'm going to start off with a definition of intersex from the UN. Then I'm going to focus on some Australian demographic issues. And I'm going to recap quickly some of the contents or materials from Bonnie's webinar, in case people maybe haven't seen that, but also just to give a kind of a very short refresher. I'm going to focus on some issues around medicalisation, around human rights developments, around pinkwashing, and about goals and barriers. And I need to give a kind of a content warning that this contains some descriptions of human rights violations and abuse, including in medical settings. I'm going to cite a number of medical journal articles, human rights reports, and government statements. And it's going to be quite a bit less personal than Bonnie's presentation. But if you want to see some aspects of my personal story, you can read some of that on the Intersex Day website. The link is a couple of slides back, but I'm sure you can find it. So to start off, this is a definition of intersex from the UN, who say that intersex people are born with sex characteristics that don't fit typical definitions of male and female. It's a very simple definition, very short. It focuses on our bodies rather than our identities. And the UN High Commissioner for Human Rights has also commented that because our bodies don't comply with typical definitions of male or female, intersex children and adults are frequently subjected to forced sterilization and irreversible surgery, and suffer discrimination in schools, workplaces, and other settings. So we're going to talk about some of those issues today, and that's why the content is there. To start off with, just to recap some of the demographic data from the study that Bonnie talked about very eloquently a couple of weeks ago. I'm going to talk briefly about this demographic, the demographic aspects of that study, where 272 individuals born with atypical sex characteristics participated in what is the first kind of sociological study of Australian intersex people. The age range went from 16 to 85 plus, and there were more than 35 different variations in that study. It was an independent study led by Dr. Tiffany Jones of the University of New England, and myself, Bonnie, and Gary and Sarah, then of the National LGBTI Health Alliance, were part of the reference group. It's also worth noting that the language that we used about atypical sex characteristics and the distribution methods helped us to reach people who perhaps prefer a different language to talk about their bodies and their intersex characteristics. And people have a range of different ways of understanding their bodies and their lived experience. Because of that, I think we got some really important information about the kind of the diversity of people's understandings of themselves. So to start off with, this is about, this slide shows issues around sex assignment and gender identities. So we can see here that 52% of respondents were legally assigned female at birth, and 41% were assigned male, with a variety of other kind of uncertainties or other options. And there are some complexities about asking about birth assignment. For example, you can see the quote on the slide about being christened male, but we assigned female at day 5. Yeah, and it's not really quite certain, how that person would respond to the survey question. It was the first time the survey was done, so I think that there can be some learning from that about what we can do better next time. You can also see how people identify themselves now, or the kind of sex classifications people prefer to use. And 52% of people in the study prefer female sex classifications, 23% male, and there are again a variety of other options, amounting to about 25% of the respondents. So what we can see here really is that one size does not fit all. Intersex people are very diverse. It's also evident that we are more likely to transition than the general population. But actually we're also very likely to identify with legal sex assigned at birth. And moving on, we can see similar variety in terms of people's sexual orientations. 48% of respondents in the study are heterosexual, while 10% prefer no label, 4% another label, 10% asexual, and a variety of LGB or queer identities. So here we can see then that we're more likely to be same-sex attracted than general population, but we're also very likely to be heterosexual. And it's a reminder that when we talk about LGBTI populations, we are also talking about people who are heterosexual. And in the case of many intersex people, we're not just talking about people who are heterosexual, but we're talking about people who are cisgender and heterosexual, to use the kind of language that people use around being transgender or not, or same-sex attracted or not. So we're very diverse. When it comes to people's sex characteristics, so there were more than 35 different variations that people in the study have, including intersex variations like 5-alpha reductase deficiency, complete or partial androgen sensitivity syndrome, Mayer-Rokitansky-Kuster-Hauser syndrome. These are very long and technical terms, that they're diagnostic labels, and they all have very different impacts on people's bodies, and many of them themselves are spectrums where there can be greater or lesser impact on people's bodies. Now what this means, when we look at the sex characteristics, these are diagnostic labels, and diagnostic labels are one kind of type of descriptor that people use when talking about their characteristics. And in the blue here, you can see the words people use to describe themselves to themselves. In the green, you can see the words people use with family and friends. And in the red, you can see the words people use in accessing medical services. And you can hear that there are a variety of different ways in which people understand their sex characteristics. 60% of people use the word intersex in some form or another, whether it's talking about being intersex, or having an intersex variation, or having an intersex condition. And you can also see here that fewer people will use that language when talking to other people than they will understand for themselves. People also use their diagnostic labels. People use chromosomes. People use also some clinical language around difference of sex development or disorder of sex development. And often people combine these different terms or use different terms in different settings. So one example of that that's very clear is the clinical label disorder of sex development, or DSD, where only 3% of people will use that language to describe themselves to themselves or with family and friends, but 21% will use that label when talking to doctors or accessing medical services. And from an OII Australia perspective, this shows that intersex people clearly feel a need to disorder ourselves to access appropriate medical care. And it also means that the clinicians maybe aren't getting a very clear understanding of the language that people prefer to use ourselves. Moving on, we're going to move away from the kind of basic language around gender identity, sexual orientation, or sex characteristics, and focus on some more data about people's life experience. I'm going to start off then with some information about educational attainment. And here, some of the most crucial information is in the percentage of people that only complete primary school and don't complete secondary school. And here we can see that 18% of people in the study only managed to complete primary school and didn't complete secondary school. And that compares to 2% of the Australian population. That's an astonishing degree of difference. It's almost an order of magnitude higher. And then there's some very clear examples of why this is the case, including bullying and stigmatization because of people's physical characteristics, but also the impact of medical interventions during puberty. At the other end of the chart, we can see how people that do complete secondary school go on to have a higher participation in undergraduate and postgraduate education. So it's not all bad. But the issue about people being able to complete secondary school in the first place is really quite important. I've got here a couple of examples of the kinds of rationales that people gave for not completing secondary school. And this is where the content learning comes into play. So the descriptions here are the descriptions people use to describe themselves. And here we can see a very clear case of discrimination and stigmatization based upon somebody's physical characteristics. We can also see some evidence of unforeseen impacts of medicalization. In this case, completely unforeseen, like a case of septicemia after genital surgery. In a woman with the intersex condition, partial sensitivity syndrome. Now, septicemia could be regarded as being unforeseen, although genital surgery can have very long recovery times, which may be entirely inappropriate for people who are at school with the kind of activities that are required at school. And here we can see another example of a woman with the intersex variation Mayer-Rokitansky-Kusterhauser syndrome. And this again, that's her description of herself. And we can see how she'd had very major invasive surgery, and both the time off for that surgery and the recovery were very challenging in the school context. Moving on. We can look at income, and this shows what may be a consequence and part of moral participation in education. I think we would expect to see something more like a normal curve on this chart. but in the intersex cohort, in the respondents to the survey, 63% earn under 41,000 Australian dollars, and 41% earn less than $20,000. As well as being low due to lower participation in education, there are also issues here about a slightly higher than average percentage of people who have a disability compared to the general population. The figure is 27% in the study. But there are very significant issues here about poverty in intersex populations. Moving on, the survey found that respondents had experienced what is suggested to be a pattern of institutionalized shaming and coercive treatment. 60% of people had received treatments on the basis of their sex characteristics, half at under 18 years of age. And that's an age when people cannot really consent themselves to those medical interventions. 44% of people reported counselling, training, or pressure from institutional practitioners, such as doctors or psychologists, to reinforce gendered behaviour, and 43% had experienced that from parents. Overall, in terms of people's mental health, 60% had thought about suicide, and 19% had attempted it. And the figures for self-harm are comparably high. In terms of people's personal experiences, some kind of illustrative cases can be seen here now. Here's the case of an intersex female with complete AIS, age 37, who talked about her gonadectomy, or the removal of her testes, in this case, existing in her memory as some kind of from her parents, family, doctors. In this case, an intersex woman with XXY sex chromosomes, age 24, we can see how she was pushed onto testosterone at age 15. And testosterone is the typical or standard protocol for people with XXY sex chromosomes, generally perceived to be men. That is not true in every case, and in this case, it was clearly inappropriate for the individual. This is a man with the intersex variations of partial AIS and hypospadias, age 24, who in this case felt that he was given inadequate information about risks and left with significant issues about intimacy. He also was not given very clear information about peer support. Now, not everybody in the study has experienced medical interventions, including genital surgeries. And in this case, an intersex female with partial AIS, age 32, she describes how everybody's genitals can look a bit funny and nobody looks like the ideal. No, she enjoys what she has. So these stories kind of illustrate the medicalization of intersex bodies and the kinds of life experiences of people born with intersex bodies. But how did we get here? Historically, if we go quite far back before the growth or development of modern Western medicine, then intersex bodies were not medicalized. No bodies were medicalized. People sought help when they had to. And if we look back, quite far in terms of canon law, Roman law, if we look at some non-Western societies, then there was an acknowledgement that people with non-standard bodies exist, and particularly in terms of canon law and in kind of the very early forms of common law in English-speaking societies. There was an assumption that there were men, women, and hermaphrodites would be regarded in line with the predominant sex in that individual. So they'd be treated as men or women depending on what was predominant. But with the rise of medicalization, we've seen a growth in medical interventions. And those medical interventions kind of focus on this issue about, or have focused on this issue about the idea that it's easier to build a hole than it is to build a pole. It's very simple or maybe even very reductive to say that, but here you can see an example from 1992 about the surgical management of intersexuality. Because it is simpler to construct a vagina than a satisfactory penis, only the infant with a phallus of adequate size should be considered for a male gender assignment. And when you're looking at surgical management, then a male gender assignment or a female gender assignment requires surgical interventions to make bodies appear more stereotypically normal for that assignment. This comes with very significant consequences, not only the consequences of incorrect gender assignment, but also this, loss of sensation. It's quite remarkable that as late as 1993, clinicians were writing that no one has complained of loss of sensation, even when an entire clitoris was removed. In an article, in a medical article about clitoroplasty for larger clitorises due to what's now termed CAH without loss of sensitivity. Underlying this, we see sex assignment concerned primarily with the surgical potential that is inherent in a body, rather than what the person with that body wants themselves. And the management philosophy is based upon two beliefs, so says Mickey Diamond and Sigmason. The surgical model was based upon a belief that individuals are psychosexually neutral at birth, and that healthy psychosexual development is dependent on the appearance of the genitals. And these philosophies come from the work of John Money and John Money's colleagues, and it was developed in the 1950s. We can see here that just before the turn of the new millennium, this management philosophy was still prevalent. And indeed, we can see aspects of this still today. We can also see here in this paper from 1987 that there is a long history of claims of improved diagnosis, improved surgical interventions, and newer, improved operative techniques. Again, these claims still persist today. There was a bit of there's been a challenge to that kind of surgical management of intersex bodies. And this is one of the key events in that challenge. It's the first public demonstration by intersex people anywhere on the planet, as far as we're aware. It took place outside a pediatric conference in Boston in the USA on the 26th of October 1996. This event is now commemorated in Intersex Awareness Day every year. So the challenge that intersex activists like the ones in this photograph made against clinical treatment led to what was, at the turn of the century, perceived to be a bit of a crisis in pediatric medicine. And it led to some of the activists who were involved in intersex activism at that time even being invited to speak at clinical conferences. However, there was retrenchment. And 10 years on from the Boston demonstration, there was what is called the Chicago Consensus Statement. And this was a statement that was developed at a meeting in Chicago, led by clinicians, with two intersex people present, one who was an observer from Europe and one North American activist called Cheryl Chase Boland. She uses both names. From what I understand, well, Cheryl Chase was not involved in discussions about surgical rationales, but was kind of sidelined into other areas of discussion. And the consensus statement that resulted from the meeting is quite a conflicted document. It talks on the one hand about how appearance-altering surgery is not urgent, but on the other hand, it provides a series of rationales for early surgical management, including what it talks about as satisfactory outcomes from appearance-altering surgery. So those are cosmetic outcomes. It talks about rationales such as minimizing family concern and distress and mitigating the risks of stigmatization and gender identity confusion of atypical genital appearance. Now, those kinds of rationales might as well have been derived from the 1950s in the work of John Money, but we can see how they remain very relevant today. The consensus statement is 10 years old. It's from 2006, but this consensus statement is seen as foundational today by clinicians working in pediatric medicine in this field. 3 years ago, we were fortunate to have an inquiry by the Senate Community Affairs Reference Committee on involuntary or coerced sterilization. And a number of clinician organizations, actually very few clinician organizations, but some important clinician organizations made submissions to that inquiry. And these are some extracts of a submission to the Senate inquiry by the Australasian Pediatric Endocrine Group. And we can see here how the 2006 consensus statement in Chicago is used to justify surgical management to modify the appearance of enlarged clitorises or, it says, repair or construction of the urinary outlet to the end of the penis. The rationales are stated as for functional reasons, such as to allow a male individual to urinate while standing, and for psychosocial reasons, such as to allow the child to develop without the psychosocial stigma or distress associated with having genitalia, incongruous with the sex of rearing. Now, looking at these rationales, I would argue that allowing a male individual to urinate while standing is actually a social reason, not a functional reason. Not every man is able to or can urinate while standing, including, for example, wheelchair users, trans men. There are many different ways of being male or a man in society than are allowed for in such rationales as stated here. Now, I'll come back to these issues about psychosocial stigma or distress a bit later on. But next, I'd like to just flag some consequences or outcomes from these surgeries. And what APEG says in that same submission is that there is limited evidence reporting long-term outcomes of early surgical management for reasons of appearance. And they themselves have particular concern regarding sexual function and sensation. So we can see a privileging of appearance over sexual function and sensation. So we can see here that the idea that boys or girls have to look normal is seen as being far more important than any issues about sexual function or intimacy, capacity for intimacy later in life. We can also see how the Australasian group say that international guidelines, the consensus statement, recommends long-term follow-up of children with DSD who have early surgery, but this does not occur in Australia. It's a bit of a fundamental problem. APEG was not the only clinical body to make a submission. I mentioned earlier that we've seen long-standing suggestions that clinical practices have improved dating back to the 1980s. And here we can see the same kinds of assertion made by the Royal Children's Hospital of Melbourne in its submission to Senate inquiry. It says that we now have increased medical knowledge and better surgical techniques. However, they also acknowledge that outcomes related to current approaches remain to be established. Now, what does this mean? If we look at a global context, we shift to the global context, the 2006 Chicago statement has had a follow-up, and here's an extract from that follow-up. The Global Disorders of Sex Development Update since 2006, published in February this year. It says, there is still no consensual attitude regarding indications, timing, procedure, and evaluation of outcome of DSD surgery. The levels of evidence of responses given by the experts are low. Timing, choice of the individual, and irreversibility of surgical procedures are sources of concerns. There is no evidence regarding the impact of surgically treated or non-treated DSDs during childhood for the individual, the parents, society, or the risk of stigmatization. So really, everything that we've seen in the APEG submission, and also everything that is visible in the RCH Melbourne submission, are based upon what are termed, expert beliefs. There is actually no evidence. Outside, the field of intersex-related surgical interventions, there's been a shift toward evidence-based medicine, but there is no evidence to support medical interventions on intersex bodies during infancy, childhood, or adolescence. And I will come back to this issue about consensus. What is consensus? There were claims of consensus by APEG, there were claims of consensus in 2006, but there is still no consensual attitude regarding surgeries now. Effectively, clinicians have been forced to acknowledge this. We will also see some material from the Senate inquiry that APEG and RCH Melbourne submitted to a bit later on. What I want to move on to maybe before I move on, I'm citing myself here, which I know is a bit of an odd practice, but what we can see in the Chicago statement and the 2016 global follow-up statement is a very conflicted document. The authoritativeness and the consensus in those documents does not actually lie in comprehensive clinician input, because clinicians who disagree with the approach were not included, particularly clinicians who work with adolescent or adult patients. And we also see a lack of meaningful community input. The idea of clinical consensus is powerful in its utility to justify clinical interventions. So ultimately, what those two documents do, the 2016 follow-up statement and the 2006 Chicago statement, is that they have been used to validate customary practices. I'm going to come on to the consensus again a bit later, talking about human rights. I want to move on now to parents. We've seen how there are beliefs that medical interventions can tackle parental distress. That is explicitly in the 2006 consensus statement. But Liao and Creighton in the UK wrote an editorial in the British Medical Journal in 2015, where they stated that parents may not realise they are de facto opting for experimental surgery on their children. Their emotional states may not be optimal, and there is evidence of high rates of parental regret. And actually, speaking as a co-executive director of OI Australia, we find that many parents come to us either when surgeries have not turned out as expected, or their child has a gender identity that turns out to be not the one that was surgically reinforced. So we can see this parental regret in the parents that come to us. And, you know, we want to be non-judgmental in terms of how we work with those parents, because they and their children need support. What we can also see in the Liao and Creighton paper is that we still lack non-surgical care protocols. And this perhaps is one of the most significant indictments of current medical protocols, that we actually lack protocols that effectively support parents who do not wish their child to undergo surgeries. This really shows how surgical management remains central to the treatment of infants and children with intersex traits. The use of IVF to eliminate embryos with intersex traits is a new front line for the intersex human rights movement. And in some ways, we can see here a consequence of the failure of surgical management to produce satisfactory outcomes, that the complexities involved in dealing with parents who are concerned about intersex traits and the kinds of surgical outcomes that intersex people experience means that IVF is an increasingly attractive means of preventing birth of people with intersex traits. It's a very complex issue in some ways, but one of the complexities is that parents are not so much responding perhaps to the issue of their child having an intersex trait, so much as much as they are responding to issues about perceptions of same-sex attractiveness or gender non-conformity. I'm going to show you a couple of examples of this. In 1990, the clinician Heiner Meyer-Barberg wrote a paper in the Journal of Child and Adolescent Psychopharmacology entitled "Will Prenatal Hormone Treatment Prevent Homosexuality?" And at that time, 26 years ago, he wrote that there was insufficient scientific groundwork to support the introduction of prenatal hormone screening or prevention of homosexuality. But his research, that research, was based on the examination of infants and children with intersex traits, what he calls human research on endocrinological abnormalities associated with physical manifestations of intersectionality. That research has continued, and this paper from 2010, 20 years on, shows rationales for a prenatal hormone treatment for an intersex variation called congenital adrenal hyperplasia. And the research in the Annals of the New York Academy of Sciences describes how without that prenatal therapy, the masculinization of external genitalia in females is potentially devastating, carrying the risk of wrong sex assignment, difficult reconstructive surgery, and subsequent long-term effects on quality of life. But we can also see here very clearly the problematization of gender-related behaviors, what are perceived to be issues around childhood play, peer association, maternalism, aggression, and sexual orientation. And the use of prenatal treatment was anticipated to reduce behavioral masculinization, as well as difficulties related to reconstructive surgeries. The idea, there's a problematization of people's gender identity and sexual orientation intertwined with issues about people's bodies. Summarize that this is some research, or this is from a press release by the Hudson Institute of Medical Research last year, where genetic researchers have identified a new syndrome leading to intersex. And they say 1 to 2% of live births are intersex, which can result in psychological trauma, infertility, lifelong endocrine care, multiple surgeries, and increased risk of conditions like gonadal cancer. There are many issues that are conflated together here, and there is a lack of recognition that unwanted medical interventions can themselves be a significant cause of psychological trauma. Many of these issues, again, lack any consensus about their necessity or indications. So what is going on here? You can see how problematization of or how the medicalization of intersex bodies promotes genetic research to help prevent intersex births. So here I'm going to leave the discussion about medicalization and move on to the human rights context. This photo is from 2013, just 3 years ago, at the third International Intersex Forum in Malta. And that meeting led to a very powerful statement signed by representatives of 30 intersex organizations from around the world. And I encourage people to consider having a look at that document. Just to start then, what are the goals of the intersex human rights movement? This looks a bit like a long list, but it kind of all comes down to the first line about self-determination. The intersex human rights movement seeks self-determination about our bodies and our identities. So we seek bodily autonomy or physical integrity. We want informed personal consent to medical interventions on our bodies. We need access to peer support because autonomy is relational. It takes place within the context of stigmatization and poor quality medicalized information. And we have, to ensure justice, we need to ensure that people have access to other people with similar lived experience. It's a very basic principle that applies to many disabilities, applies in many other fields. How many people would imagine that you can live happily with, for example, HIV if you have no access to anybody else with HIV? If you don't know anybody else with HIV, if you're told to keep it a secret. So access to peer support is essential. We also need legal protection from harmful practices, including mutilations. And we need human rights-based clinical pathways that affirm people's rights to the enjoyment of health. Those of us that have experienced medical interventions need reparations and justice. We also need recognition of our diversity. And here I come back to the demographic information I shared earlier from the study in Australia. We're very diverse in terms of how we understand our sex, our gender identities, our sexual orientations, and how we understand our bodies. We need recognition of that. We need people to understand that we're intersex men, intersex women, people with non-binary gender identities. And ultimately, we need to end shame, secrecy, and stigma. We really want the same rights as our non-intersex peers. Over the last 20 years or more, a lot has happened. See, a lot even in just in the past few years. In 1996, there was that first demonstration at the Boston Pediatric Conference. In 2005, there was a South African anti-discrimination law, and also a report by the San Francisco Human Rights Commission. And that report is really well worth reading. Not much has changed. It's about your clinical practices. In 2006, there was the Chicago Statement, and at the same time, the Chicago Statement was stating rationales for medical intervention based upon mitigating the risks of gender identity confusion via surgical management. The Yogyakarta principles include a principle 18b on ensuring that children are not subjected to medical intervention to impose a gender identity. Those two statements are in conflict with each other, and so far the Yogyakarta principles have not really been applied to the situation of people with intersex traits. That has to change. In 2008, there was the first successful legal case against involuntary or coercive medical interventions by a woman called Christiane Wolling in Germany. That's one of a very small number of successful legal cases. There are some barriers to legal cases around intersex traits, including the statute of limitations and claims of clinical consensus about surgical management. In 2012, the Swiss National Advisory Council on Biomedical Ethics produced a report on what it called intersexuality. In 2013, we saw a number of events. We saw a report by the UN Special Rapporteur on Torture. There was a third International Intersex Forum. And locally in Australia, we won protection on grounds of intersex status and anti-discrimination law, as well as a science inquiry and report on the involuntary or coerced sterilisation of intersex people. In 2014, there was a World Health Organization and UN interagency paper on involuntary or coerced sterilisation. And there was also kind of a global intersex human rights movement submission on reform of the International Classification of Diseases made to the World Health Organization. Last year, Malta became the first country to prohibit coercive normalization of infants and children with intersex traits, and Chile was suspended surgical management of sex bodies. Same year, there was a UN expert meeting on intersex human rights and reports by the Council of Europe and the Inter-American Commission on Human Rights. This year, there was a major report by the Asia-Pacific Forum of National Human Rights Institutions, and the United Nations has published a website and a very powerful statement. The website is called United Nations for Intersex Awareness. It's well worth checking out. I'm going to explore some of these statements in a little bit more detail. This first slide is from the report by Juan Mendez, who is the UN Special Rapporteur on Torture and other cruel, inhuman, and degrading treatment or punishment. And he found that children who are born with atypical sex characteristics are often subject to irreversible sex assignment, involuntary sterilization, genital normalizing surgery performed without their informed consent or that of their parents in an attempt to fix their sex, leaving them with permanent irreversible infertility and causing severe mental suffering. US Special Rapporteur on Torture recommended that states, countries, repeal laws allowing intrusive and irreversible treatments, including outlawing forced or coercive sterilization in all circumstances. Unfortunately, many of these issues remain very relevant in Australia. In 2013, there was an inquiry by the Australian Senate on the involuntary or coerced sterilisation of intersex people. The National LGBTI Health Alliance, which is very kindly supporting this webinar, was the only LGBTI organisation to make a submission. Although there were, of course, numerous submissions by intersex-led organisations like AIS Australia and OAI Australia. The report of that inquiry acknowledges that there is no medical consensus around the conduct of normalising surgery. The report comments that normalising appearance goes hand in hand with stigmatisation of difference. And the use of psychosocial rationales such as risks of gender identity confusion, parental distress, social stigma. These rationales are questioned by the Senate's report. They say that there is great danger of psychosocial rationales being a circular argument that avoids the central issues. There are very few other cases where people's bodies are modified to prevent stigmatization with the kinds of consequences that we see with intersex genital surgeries. Just as an example of this, I've heard clinicians compare genital surgery, genital interventions on intersex people to the removal of a sixth finger on somebody's hand. It's something called polydactyly. But if we think about this, if that kind of surgical intervention led to the same kinds of consequences for manual function and sensation as genital surgeries have on sexual function and sensation, then I can't imagine that those manual, hand, finger-related surgeries would continue. There's quite a fundamental difference here. A fundamental issue here. The issue is about affecting people's capacity for sexual function and sensation, the capacity for doctors to get somebody's gender identity wrong. These issues do not occur when it comes to cosmetic surgeries on the hands of infants and children. A bit of a detour there, but let's come back to a couple more human rights documents. This is a report by the Council of Europe Commissioner for Human Rights, published in 2015. And this was the first human rights report to actually say explicitly that intersex persons' right not to undergo sex assignment treatment must be respected. Very simple statement. It's the first time that that's been said. The report also said that medical classifications that pathologize variations in sex characteristics should be reviewed. And this is one I think is very important. Moving on, also last year, Malta introduced the first law to ensure that medical interventions driven by social factors will be prohibited. What Malta did was Malta recognized a right to bodily integrity and physical autonomy. The legislation states that it would be unlawful for medical practitioners or other professionals to conduct any sex assignment treatment and or surgical intervention, which can be deferred until the person to be treated can provide informed consent. This provides a very important model that is applicable in all common law countries, including Australia. In the same year, 2015, the United Nations High Commissioner for Human Rights, Zeid Ra'ad Al Hussein, said in introducing an expert meeting on ending human rights violations against intersex people that all human beings are born equal in dignity and rights. And those foundational bedrock principles of universality and equality mean that all of us, without exception, and regardless of our sex characteristics, are equally entitled to the protections of international human rights law. Again, this is the first time this has been said, and it has direct relevance to practices in Australia. This year, the UN and an incredible array of different organizations, including the African Commission on Human and People's Rights, the Council of Europe Commissioner for Human Rights, the Inter-American Commission on Human Rights, as well as the UN Committee Against Torture, Committee on the Rights of the Child, Committee on the Rights of People with Disabilities, issued a joint statement. And they say states must, as a matter of urgency, prohibit medically unnecessary surgeries and procedures on intersex children, upholding our rights to health, to physical and mental integrity, to live free from violence and harmful practices, to be free from torture and or treatment. And they also said that states should investigate human rights violations against intersex people and hold those found guilty of perpetrating such violations accountable, providing redress and compensation. This year, there's also been action within the Asia-Pacific region. The Asia-Pacific Forum of National Human Rights Institutions has published a really excellent report on promoting and protecting human rights in relation to sexual orientation, gender identity, and sex characteristics. And tackling a slightly different issue in this slide, well, I should say that they repeat the same statements about medical interventions. But here, what I've picked out is are some issues about recognition before the law. And the Asia Pacific Forum says that recognition before the law means having legal personhood and the legal protections that flow from that. That is neither primarily nor solely about amending birth registrations or other official documents. And firstly, it's about intersex people who have been issued a male or female birth certificate being able to enjoy the same legal rights as other men and women. And this includes, for example, freedom from female genital mutilation. It includes access to sport on the same basis as other men and women. The report acknowledges that some intersex people seek to amend sex or gender details on official documents, and this should be enabled as simply as possible. And it also says very clearly, in line with the Malta Declaration of Intersex Forum, that it's not about creating a third separate category for the registration of people born with intersex trait. Doing so is discriminatory. The Asia Pacific Forum acknowledges, as intersex-led organizations do, that third or non-binary or multiple options should be available for people who are able to freely consent to them. So these slides kind of encapsulate some of the human rights issues involved in the treatment of people born with intersex traits or variations. In Australia, though, we've seen what can really be called pinkwashing. We can see what I state here is our disjunctions between social and medical policy, often on individuals with DSDs, on children with DSDs, and how that differs from social policy that are for social policies for the intersex or broader LGBTI communities, or sometimes the transgender intersex community. There are also differences between rhetoric and reality. I'll show some examples of this. So here, in the first example from Victoria, we can see how the Department of Health and Human Services has published a guide called Rainbow Equality, that's celebrating and valuing diversity, removing discrimination, including a diversity of sexualities, gender identities, and intersex variations. And at the same time, the same department publishes on the same website this material about the birth of infants with ambiguous genitalia. Neonates is a newborn infant. So ambiguous genitalia in neonates is rarely anticipated. It can be a source of great distress for parents, delivery room and nursery staff, and even a medical emergency. And the document says that corrective surgery is usually undertaken within the first year of life. It describes surgical interventions, or the timing is controversial. However, very early surgery is less common. Very early surgery is under 6 months. The same documentation talks about how girls require surgery to, what it says, restore genital appearance to normal, whatever normal is. So these comments appear on the same website as this, but the audiences are a bit different. At the same time that this is stated, we can also see in some documentation by the Department of Health and Human Services in Victoria some decision-making principles for the care of infants, children, and adolescents. We can see some statements about minimizing psychosocial risks to the child, including risks of social or cultural disadvantage, for example, reduced opportunities for marriage or intimate relationships. This is a bit controversial. It's proved controversial. The decision-making guidelines were published in 2013. They've recently been modified. Well, the data stayed the same, but the word marriage has been removed. This feels a bit unexpected. Just discovering that the document has changed without any notification, without any change to the date of the document. The original wording is still documented because it's cited in the Senate report on involuntary or coerced sterilization. We can also see issues with what I would call pinkwashing in ACT. In 2014, the ACT government created a third sex marker for infants, treatments, and adults. And this was portrayed as concluding the territory's work to promote the rights of transgender and intersex people. So we see here a statement from the Chief and Health Minister at the time, stating that the availability of the third marker for children will reduce the risk that parents will force their child to conform to a particular gender or subject them to gender assignment surgery to match the child's physical characteristics of the chosen sex. This was in April 2014. But just a couple of months before that, the same minister wrote to me about the Senate inquiry into involuntary or coerced sterilization, because I was writing on this issue. And at that time, she said, currently in the ACT, the event of the birth of a baby with a DSD, clinicians follow a consensus statement, and that consensus statement includes surgery that should be performed in centres of excellence. So children with DSD are normally referred for surgical management to either Melbourne or Sydney. So just compare these two documents. One talking about children with DSDs, and the other talking about a third sex marker for transgender and intersex children, in this case, particularly for intersex children. These documents, these letters, contradict each other. And even though they're signed by the same minister, we can see how different people within different ministries in the ACT are, put it bluntly, not talking to each other. There is no clear understanding about the affected population. We have that as an intersex organisation, but governments in Australia are still not getting to grips with these issues. Another example of this can be seen in South Australia, where just last week the Premier of South Australia referred to intersex people in an apology to the LGBTI community. But the only substantive mention of intersex was something to do with identity recognition. This seems in some ways quite extraordinary, that there is no acknowledgement of medicalisation, only this kind of misinterpretation of intersex to be solely a gender identity issue. So there are many barriers to achieving human rights for intersex people. And I'd like to ask for your help. I'd like to ask for your help in tackling barriers to familial and self-understanding and barriers to social connectedness that can help individuals with intersex traits to overcome stigma and discrimination. And that includes things like talking about intersex in ways that reflect our diversity, that reflect the human rights and medicalisation issues that I've talked about. I'd like to ask for your help to tackle the rhetoric of change to clinical practices that we can see. I'd like your help to tackle the limited disclosure of actual practices, the removal of information from documents that helps us to identify what's happening. I'd like for help to create human rights-based pathways for parents, children. And we also need to tackle the rhetoric of inclusion in ways that limit our self-determination to assumptions that we all identify in particular ways, in ways that fail to acknowledge our diversity. And this includes governmental, media, and institutional framing of intersex as a gender diversity issue. I hope that this has been helpful. I hope it's identified some of the issues that face intersex people, both in Australia and in other countries with similar healthcare systems. I've tried to well reference material I've presented, so I hope that you're able to maybe review this and note down some of the references if you want to pursue anything further. But a good starting point is the new UN website, United Nations for Intersex Awareness. And there's the web address. So I'm going to close with that, and I'd like to thank you very much for listening to the webinar. I'm sorry that I'm not here live to take questions, but I'm very happy to take questions via email. I think Charlie at the Alliance will send on questions to me. Thank you very much.
So thank you so much, Morgan. Really appreciate you taking the time to go through the human rights and medical perspective for intersex, people with intersex variations. I've popped up Morgan's website up here if you want to read more about what Morgan's up to, but also make contact with Morgan directly. My email's there, charlie.wilbridge@lgbtihealth.org.au. So please, any questions or access to more resources, they will get through to Morgan, and we'll have resources up with the webinar on the Knowledge Hub on our website. So thank you again, Morgan. Appreciate your time, and we'll see you at the next webinar. Thanks, folks.